Right. Welcome, everybody. Um, we're now going to have an interesting session on back pain in sport, where we've asked Dr. James Robson, who has a glittering career in looking after various teams. He started in 1980 when he qualified as a physiotherapist and worked in the Royal Infirmary of Edinburgh for a couple of years, which is where I work now. Qualified the same time as me, and our careers have been rather parallel in and around Edinburgh. But he went on then to become a medical student in Dundee, then qualified in Dundee, was a GP for 13 years, and gradually took an interest in sports with the Scottish rugby team, first as physiotherapist, and then as the medical support, culminating in 1993 to 2013 with 6 consecutive British Lions tours as the team doctor. And he continues as the Scottish team doctor. You'll have seen him many times running onto the pitch. You might have seen him running on the pitch to help Will Greenwood when he was knocked out back in the 1990s, and Tom Evans when he was playing in Cardiff and had that terrible neck injury. And fortunately, both have recovered and are thriving thanks to his great skills. So we wanted to ask him what it's like to manage this range of injuries that players get into, and get his perspective on his sporting life. So I'll now pass you over to James Robson's talk, after which we can have quite a long period for questions which you may have.
Hi, everybody. Nice to meet you, albeit virtually. Difficult for us at the moment. Apologies for the background, in camp with the Scotland team and stuck in the hotel. Sounds awful. I'm going to speak today about spinal injury as we see it in rugby union. Hopefully some of you will be able to relate to it, and we can have a discussion afterwards. On the pitch, of course, we tend to get 2 types of spinal injury. The one that worries us most is the serious, potentially catastrophic injury. Very scary for both clinician, pitchside carer, and the player. There's nothing worse than running onto a situation where the player says, I can't feel my legs. That management, of course, is determined largely by good pitchside care, and I would commend anybody working in contact sport to attend and pass a pre-hospital trauma type course. The less serious may manifest itself during the game, or quite often after the game, or indeed during the working week. Very difficult. Of those 2 types, we get the fractures, which tend to declare themselves almost immediately, albeit requiring further assessment and usually imaging to determine that diagnosis. And we get the what is becoming more increasingly common in contact sport, the disc lesions. The discs may present themselves in a variety of ways. We have people who come off because of the injury, declaring various symptoms, or we find more often, perhaps the day after. Of course, disc injury may result from an incident several weeks previously, such as the mysterious involvement. If I use myself as an example, I got very, very severe discogenic pain, having done nothing apparently the previous day. I relate it to an episode perhaps several years previous of similar symptoms, which settled of their own accord. History taking, therefore, can be absolutely key and paramount. Listen to what the player is saying. Quite often, they'll relate to the fact that, yeah, it seems strange that I couldn't do a push-up, or I couldn't do this or that in the gym. And I didn't think it was worth mentioning because, of course, they may find that their function is at very high level. Examination, the routines, looking at the function, looking at the movement patterns, testing the reflexes, checking sensation, and measuring power. Ideally, if you're in the position to have done some baseline testing, such as grip strength, then of course you can use that as an objective marker. Further to the aid of your clinical acumen is imaging. We by and large tend to use MRI, and the relationship that you develop between the musculoskeletal radiologist or the neuroradiologist is key there, because an accurate diagnosis may help enormously in your rehab and management plan. And last but not least, of course, we need our friendly orthopedic spinal surgeon or our neurosurgeon, of which we've all got our favorites and those people that we trust. For fractures, that management is largely led by pain and by consultation with the medics, the spinal surgeons. With the discs, it tends to fall into two camps. We get those discs that settle within the sort of 6-week time frame that we've all come to know and love, and that was the case for myself. Severe pain one day, gradually easing with movement, with medication, and finally recovering enough to function normally at 6 weeks. Or you get the more troublesome, more worrying, moderate to severe discogenic problems lasting around 3 months. It's odd that it falls into these two camps, but there's very often very little between the two. Management, of course, rest in the first instance, but active rest dictated by just the symptoms, the pain, and their functionality. The medical side may involve medication, such as analgesia, preferably the likes of paracetamol or ibuprofen, or your choice of non-steroidals. If they're not helping, then you may try amitriptyline or gabapentin, progabalin, whichever your medic advises. From a point of view of intervention, if the MRI shows a severe lesion, you may and would advise you to consult with your neurosurgeon, your orthopedic spinal surgeon, and decide whether surgery is a required intervention. By and large, we find that even the more severe end of the disc lesions are treated conservatively in the first place. An intervention which I have used very little, but is used by many of my colleagues, the interventional radiologist may provide local injection with steroid and local anesthetic. Whatever medical route you go down to making the patient comfortable, rehab keystones are rest and gradual return to activities of daily living driven by symptomatology. Once the player is comfortable, you can embark on a progressive strengthening and rehab program. We tend to work initially by simple isometric stabilization if it's a neck lesion, and gradually move to including limb functional movements dissociated from the stability of the neck. Provided that you're not provoking symptoms, you can gradually increase your load, working through the various stages. We're very lucky because we have a very motivated population. We, by and large, have a set of young people with a very, very fit background and a great degree of strength. That helps us over the normal course of things that the normal public would wish, such as myself, to return to high-level functioning. Previous injury may, of course, also have a bearing on that outcome. After a period of recovery, objective measures such as your grip strength with the handheld dynamometer, or as we use for neck strength, we test with the Don Gatherer system. It may be that you have other systems too. This just allows you to compare their strength and their function to their baseline pre-injury, and can largely help to declare when you might return to functional exercise on the pitch. We go through a degree of non-contact, progressing to controlled contact, non-game, and then ultimately back to the game. Of course, you have to prepare the player and the coaching staff to have a realistic expectation. It can be very difficult sometimes for people to realize that they're going to be out for a period of 3 months in some severe instances. There you might enlist the help of people that had similar previous injury. I hope that gives you a small insight into what we see in rugby, and I'd be delighted to converse with you after this. Thank you.
Thanks, James. I think there's some questions just been typed into the chat box, so we're kind of waiting on them coming in. Have you noticed changes in the type of injury now over the years from how we used to prepare people for rugby to the current training regimes that we now see that are a lot more sophisticated?
In the early years, we saw quite a lot of older players with degenerative conditions, degenerative spine, and largely, I think, down to the fact that in days gone by, training sessions could last up to 3 hours at an international level. We're much more cognizant now of trying to get quality over quantity, and sessions might last 40 minutes. Within those sessions, individual items may last 4 or 5 minutes, and they're very carefully monitored. And equipment has changed as well as reducing the amount of time we spend in training. The actual quality is dictated both by the quality of coaching and also some of the more sophisticated equipment. I remember for several years, pneumatic scrum machines, and coaches used to take great delight in cranking up the pressure coming through onto these robust individuals. And one can only think that that has had a detrimental effect on many of our older ex-rugby players to date. We tend to use very sparingly the scrum machine now, and we rely more on live scrummaging practice. But of course, that means that you have to have a certain amount of personnel available.
That's great. We've got another question here about how do you manage repeat stingers? Is there a number as a threshold for referral?
Yeah, I wish I had an answer to that. I see that not uncommonly, virtually every test match. And we have some people who are prone to stingers, whether that's down to technique, whether it's down to some kind of priming. Once you've had your first one, we manage them. We tend to be able to leave them on the pitch. Our population are very robust, but we're quite liberal in the use of anti-inflammatories. I was privileged to chat to some researchers up in Aberdeen on spinal and nerve injury, and they were suggesting that the inflammatory soup that surrounds the nerve after recent injury, if you can minimize that, then you aid recovery. Certainly anecdotally, we find the likes of diclofenac and naproxen used very early, so post-match in the normal dosage helps recovery. But repeat stingers, and if you find that functionality, loss of strength is a result of that, then that determines, speaking to people like Patrick and our neurosurgery colleagues.
Patrick, your mic's still off.
There's another question here, James, from Julia Tabra, talking about rest and neuropathic medication. Neuropathic medication in recent advice has been rather frowned upon in the NICE guidelines. But from the point of view of rest is a relative term, isn't it? I mean, these guys are super fit, and you don't want to be letting them lose fitness. So your idea of rest, or their idea of rest, is very different from mine, perhaps.
Our idea of rest is not doing yesterday's 40-minute team session. So in relative terms for injury, it's actually giving them a break from what they're normally expected to do and concentrating on the rehab. I am aware of the trend not to use neuropathic medication, but I have to say I had really quite severe neuropathic pain, and the only thing that actually helped me and kept me sane for 3 weeks was gabapentin. I think that you have to use it judiciously, and we don't use it on everybody, but it should still be there as an option. And indeed, low back pain, we see less of at the moment. Our trends are towards cervical and thoracic discomfort. And certainly we find it quite difficult to resist giving people medication. Paracetamol works immensely well, but trying to convince fit rugby or relatively fit rugby players that paracetamol, which you can buy over the counter, is a good drug, is one of my bugbears in life. But I can again testify that it certainly helped myself.
There's another question about, is there a red flags or a set of red flags that would mean that you would stop someone playing?
Yeah, again, it's going back to the NICE guidelines and looking at that. We rarely on our own stop people playing. Again, it tends to be if the injury has been so critical that intervention or secondary care advice has been sought, then it tends to be a very much a multidisciplinary team approach with the player and the surgeon and the physiotherapist and the team doctor, just relaying to the player what the pros and cons of continuing might be. But we have had some immense success with people who have had quite debilitating and worrying multi-level injury, having had surgery, and then subsequently being able to play at international level. So I think what we have to be careful of is avoiding unnecessarily ruling people out. but mindful of the fact that, you know, life is full of risks, and if you have one injury, it may set up a preponderance towards further injury, and the next injury may be actually more severe. Very much a balancing act, Elaine.
Thank you.
There's a question from Adam Jones. Thank you for your talk. How much value do you place on restoration of normal spinal range of motion prior to commencing more dynamic strengthening rehab work?
Absolutely key. We all know that range of motion is a nice indicator for then being able to do other activities. So we're very mindful, but be aware, of course. The older rugby players have already got a limited degree of motion, so it's all relative. But yeah, no, we definitely get free movement, I think, and moving pain-free is the prerequisite to getting into the gym with the strength and conditioning guys. And indeed, I was just remarking that we were having this conference today, and our head of S&C was saying that for him, that is key, actually seeing people move freely, normally, and ideally pain-free is what he needs to see before he starts work in the gym for us.
Can you tell us a bit about the strategy in Scotland for the sort of junior rugby to try and ensure that they have more protection, not only as children, but going forward in their rugby careers?
Yeah, so Elaine, of recent times, you may be aware that in football, FIFA came up with a series of exercises to be done before sessions. Rugby have now done the same. Sadly, I can't say that it's a Scottish thing. It was developed down south of the border, but we're looking at rolling this out. And certainly the evidence suggests that this will help enormously with in injury prevention. Allied to that, currently looking at more robust data collection. I think that, again, is key. It's topical today. Several emails recently just looking to see if we can set up more community surveillance. And again, that should lead things. And then lastly, each of the, certainly the home unions has the ability to vary the laws or the regulations within a game to a certain extent. And we currently are re-examining what our young people are advised to do. I think an interesting point there, looking at the return, because of COVID, looking at the return to activities in the community, I was surprised to find that the definition of touch rugby is actually enshrined in legislation. So, you know, even the oldest of us can get surprises, and it really means that you've got to liaise with lots of agencies. So in Scotland, we've got Active Scotland, we've got Sports Scotland, and then we've got the various sports governing bodies, and everybody has to have an input into the strategies of how do you bring people from the younger age through perhaps to ultimately the professional level in any sport, and to examine at each of these stages what the safety aspects are, what the development requirements are, and how you might tinker with the regulations.
There's a question from Michael Reddington. What is your experience of assessing and managing the psychological aspects of injuries and return to play?
Yeah, well, this is a fascinating subject, and thanks for the question, Michael. We've identified several years ago that perhaps we were not as good as we thought we were in supporting people, particularly with long-term injury. And so we've incorporated that into a strategy called Rugby for Life, which looks at the various aspects, both financial, physical, and mental, and a greater emphasis, particularly at the moment with COVID lockdown, has been placed on mental health as a population. For the long-term injured, we now have developed psychology support, and that's been rolled out to both our professional teams and indeed at the moment in national camp we have a psychologist in, and they are key to helping us with the mental aspects of rehabilitation and long-term injury. So I would commend the relationship between the medics, the strength and conditioning, the coaches, the player, and the psychologist.
And we have another question from Nilam Shergill about symptomatic PARS injuries. Are they becoming more common in rugby?
Yeah, we've got a difficult one at the moment. I'm not sure if they are or they aren't, but I have over the past year seen more than I have in the past 6 years. So I'm afraid, Elaine, I can't answer that question with any definitive answer.
Do you think you find PARS defects more because of greater imaging?
Yeah, I think the greater ease of access. We're very lucky in the private sports arena. We can use imaging much easier. But I think it's actually the more people that have been scanned and the more that the professionals are seeing these injuries, the more that it gets then back out into the public domain. So it heightens awareness of the issue and allows you perhaps to use your clinical acumen to drive, looking for that sort of injury. Lane, as with all things, the awareness of concussion, the awareness of injury pattern, etc. It's all about getting that information out to all our clinical colleagues and making them aware of these things.
I might ask one. I think there's a couple of other questions coming in, but in the meantime, I might just ask about the whole business of what Rick Nelson was talking about a little earlier about hypertrophic cervical spondylosis. This whole business of loading teenagers who play in the front row and then them getting premature osteophytic changes and hypertrophy of the facet joints in the cervical spine. That's, if they keep bulking up, that's only going to get worse as time goes on. Do you see, we're talking a little earlier about collision being the buzzword in the perhaps early 2000s, where the game was all about bulking up and colliding with as much force as possible. Do you see either a change in the laws or the change in the training that might mean a scrum will become a safer thing in the future?
Yeah, Patrick, I think you hit on it there. There was a tendency, and I spoke out many years ago, that rugby seemed to have become a collision sport rather than the sort of artistry that we'd known for finding the space. And actually, that has plateaued, and I think we're going back a little. The authorities are looking very carefully at how they might modify things. Of course, we have modified things. We modified the scrum engagement, and now we're finding anecdotally that people are perhaps suffering a little more than they were before. So it's trial and error. Some of it's informed by research. Some of it's informed simply by as a response to a change. The loading in youngsters is really interesting problem, because what people see at the professional level, they try and reproduce down at the community level. And I personally believe that the community level should be and is a different game, and there needs to be a pathway between those two to get from one to the other. But more and more, we're looking carefully at what's happening to the youngsters. The advent of academy systems in all sports has highlighted that. So we're bringing people in, perhaps they're at school and then part-time they're coming into the rugby or football or judo arena. And I think we need more evidence to support the thoughts that perhaps we've got to be a little more cautious in what we put our youngsters through at an early age.
Brilliant. Thank you very much. We probably have to draw things to a close now, but there is one very important question from Dermot Ferguson. Perhaps you get a clue from the name. What's going to be the result at the weekend?
Well, I've just seen it. I think the result is going to be a wonderful festival of rugby, is perhaps as political as it can be.
Great. Thanks very much indeed. Thanks.
Congratulations to how well everyone's playing.
Thanks, Elaine. That's down to the coaches. It's not the medics just pick up the pieces.
Cheers.
Cheers.
Bye.
Bye now.